Thank you, Heather. If you are here for the webinar on Trust Yourself and Take Care of Each Other about navigating COVID and long-term COVID as HIV long-term survivors, you are in the right place. So welcome everyone. We'll get started in a few minutes. And again, feel free to put your name, pronouns, where you're at, if you have an organization. How are you doing today? Let me see who's in the room. Oh, we got Vancouver up here. British Columbia, welcome. Monique, Jonathan, Beaumont. I live in Houston, but I'm in DC today. Wanda, hey Wanda. Hey girl, how you doing? Yay. Larry. Let's see, it's 1:02. I'm gonna try to get started at 1:05, everyone. And so if you're just joining us, feel free to put your name, pronouns, or where you're from, your organization affiliation, if you want to, in the chat. Welcome, Ron from New Jersey. And I may say this wrong, Shakina. I hope I got that right, from Pittsburgh.
You got that right. Thank you. Well done.
Were you at HINAC?
I was, yep.
Okay, you from Texas? Were you in the Texas group?
Pennsylvania.
Okay, I remember your name. Welcome, John from Dallas. Welcome, Wahida. Melanie, why am I not surprised to see you here? Welcome, Melanie. I'm in your neck of the woods. Eldana, welcome. 38 years positive. Y'all know we got some centuries of lived experience and subject matter expertise on here. We'll get started in one more minute. And so please say hello in the chat. Welcome, Kevin, Hector from Avita Pharmacy. I want to thank you all for taking time out of your schedules to be here, to share space with us, virtual space. Y'all know we done got used to running in these virtual streets over the last 3 years. So thank you for yet another Zoom meeting that you've signed up for and are showing up for. Hey, Chesler. Yeah. So one more minute, we'll get started. These virtual streets allow for greater participation. They do, Wanda, I totally agree with you. I've been able to look at museums in Germany and all kinds of things in these virtual streets. I went to places I ain't been to physically. Hey, Doug. God, I wish there was somebody could count up some of those years in the chat so we can, acknowledge how many years we have of lived experience on here. If folks put their number of years in the chat, because I'm seeing a lot of years. Pat Kelly, hey Pat. Yeah, so if somebody, Heather, somebody can start adding up some of these years at some point, let's talk about that. So I'm Benita and I have 20 years. So I'm going to get started. Is that okay, Heather?
Go for it.
Okay. Let's get started. Welcome, everyone. And I'm nervous and excited to be your moderator today. My name is Vanita Ray. If I don't know you, my pronouns are she, her, and ella. I am a woman living with HIV for 20 years now. I happen to live in Houston, Texas, and I've been around a little while and done some work in a lot of different places around racial justice, social justice, around you know, the meaningful involvement of people living with HIV and elevating the voices of folks living with HIV, and a lot of organizing here in Texas and in the South and across the country. So I'm really excited to be here. I'm not in a normal role for me, but I'm really excited to be here today. I wanted to talk, go a little bit, next slide, please. To do just a little bit of housekeeping, and again, keep welcoming folks. Put your name and information in the chat so we know that you're here. And if you want to drop the number of years you're living with HIV, please do. First, housekeeping, just this event is being recorded, so just so everybody knows, so you make sure this is public, that you only say what you want others to know. And if you don't want your name to be shown, feel free to change your name to something else, so that if you don't want folks to know that you're here. There's some buttons at the bottom that closed caption is available for folks. If you click on the 3 dots or more, I think that closed caption is available. Since this is a regular meetings webinar, you're going to use the chat feature to ask questions, and we're going to reserve questions to the end, but please drop your questions in the chat anytime, and we'll have folks looking out for them, and we will try to spend the last 15 minutes addressing any questions in the chat or allowing folks to ask questions or make comments at that time. So please feel free to drop any comments, questions in the chat. I've already talked about, if you want to remain anonymous, you can change your name or turn your camera off. Thank you for that. And then we want you to please fill out the evaluation at the end of the webinar, because it's almost as important as coming to the webinar is telling us how we did. I'm not a Reunion Project staff person, but I am a member. I am a long-term survivor, and I'm excited to be here. So next slide, please. And you know what, y'all? So if you don't know who the Reunion Project is, I was shocked. I'm doing this webinar, y'all, and I see myself in this picture and didn't know that I was at a meeting that they were kind of reconfirming and making it official, the Reunion Project as an entity and organization, till I saw this slide. So that shows you sometimes we show up at places we don't even know the impact of what we're doing. But the Reunion Project was started and focused really around elevating the issues of long-term survivors of HIV. And it is not about, you know, how when you were diagnosed. One of the things I really loved at this meeting, we really unpacked the issue and how we define long-term survivors. And it's not this age 50, it's not this, you know, when you were diagnosed. People, you know, long-term survivors, you could be surviving from a lot of things versus HIV, just lived experience of being a Black woman in America for me, right? Way before I was diagnosed. So it makes me a long-term survivor. And so the Reunion Project goes around the country convening and connecting individuals. They came to Houston last November, 2 days of really heavy conversation, but needed conversation, sharing our experiences. And, you know, we've been experiencing loss and a lot of other things going on in our communities. And we're dealing with 2 viruses now. So the Reunion Project, I appreciate you all so much for bringing these. I saw that they just put out a grant. I hope folks look at that. You can do your own peer-led town hall. But I will keep going unless somebody needs to say something I didn't mention about the Reunion Project. Are we good? Okay. And then before we get into the real business, y'all know we got to deal with our money issues, but we want to thank our funders, Gilead Sciences, ViiV Healthcare, and Broadway Cares for supporting the Reunion Project and enabling them to bring these kinds of programming to the community. So thank you. So now I want to talk a little bit about what we're going to talk about today. So the dealing with COVID, long COVID, in the HIV community when in 2020, what came out, it really felt reminiscent of the early days of the epidemic and the language around HIV. And the difference this time is I was a person living with HIV when another virus, was detected and really harming a lot of folks. And so what that it has produced for people living with HIV that we don't always talk about because we're kind of normalizing COVID, but we are facing two viruses now. And someone put, we've survived two plagues. Yeah, I mean, we have one virus that makes us susceptible to the second virus. So we sit at a unique intersection in this, and where folks are trying to normalize COVID, but for those of us with compromised immune systems, we still have a lot to be concerned with. I was just flying yesterday, and I was one of the only people with a mask on the plane still. That most people have gotten rid of their masks, but I understand what my issues are, and I want to live, but I got to protect myself as well. And as a Black woman living with HIV, I want to say we have the highest mortality and comorbidities of any group living with HIV. So it's just a double whammy. And so today what we're kind of talking about is something the HIV community has done for a long time. Is before the rest of the world paid attention, we had to learn how to help ourselves. We had to learn how to build our own networks. We had to learn how to treat ourselves. We had to learn how to do things for ourselves. And now, and we did it so well that other health conditions are trying to mimic what folks have done. I wasn't around in the early days, but I'm so grateful for them. The professionalization of HIV and the onset of HIV Inc. kind of reduced those support networks, and folks went into the background in some ways. And the folks who were running organizations now, the requirement became these degrees or something. So folks, we are not always in the forefront of this movement the way that we should. And now we're dealing with two intersections of movement. So, and then the communities are most impacted by COVID and HIV are the same communities: Black and brown communities, poor communities, the rural communities, our essential workers. Who are they? They're the Black and brown folks. So here we have another health disparity leveled on the same communities. And now we've lived through this early days of the pandemic, and we're in this post era, but it isn't over. We have a new normal, and we have to really think about how we take care and maneuver now dealing with these two health conditions that folks are dealing with. And today, what we're going to hear from is a couple of folks. First, Philip Shubin, who is an organizer, activist, and co-founder of the Reclaim Pride Coalition, which produces produces the Queer Liberation March. Philip strives to amplify the most marginalized voices in the LGBTQIA plus communities. And he's also a member of Rise and Resist, a direct action group formed in response to the 2016 election. So I'm going to introduce our speakers just quickly, and then you all, they'll just go on without me having to stop and introduce them again so that you all can have more time. And Gabriel, I'm really excited. Our second panelist is going to be Gabriel San Imet. I'm going to just say Gabriel because I'm going to say it wrong. And I really value people, and I don't like to say their name wrong. But Gabriel is a queer activist from Mexico City who migrated to New York City 24 years ago. They have a master's degree in social work and community organizing. They're part-time faculty at the Silverman School of Social Work at Hunter College, and they're a person living with HIV, and they also are living with ME, and I am not myalgic encephalitis. I don't know, but bring a lot of lived experience to this work, and they are fueled by that lived experience to do this work, and co-founded Strategies for High Impact. And they are the co-founder of the project that's working with the Reunion Project called Long COVID Justice in 2021. And then our last speaker is Dr. Michael Peluso, and he's an assistant professor of infectious disease doctor at UC San Francisco. And his his focus has been on the chronic effects of HIV infection in clinical trials. And if I try to read all this, y'all, it's not going to go well. But Dr. Peluso led the efforts to implement a long-term impact of infection study at the San Francisco General Hospital based on the hypothesis that COVID could have long-term impact on health and well-being. And I'm really glad that Dr. Peluso is with us today, because I don't think we really understand the long-term impacts. People like me, I've had COVID, and they said, oh, that was a mild case and you didn't have, you're all better, but I had shortness of breath for months. I didn't know what it was. And, reading and understanding about long COVID has helped me to understand some of the reasons for some of the issues I was having. So Dr. Peluso is co-investigator of a national study on long COVID, and he's responsible for some of the NIH long COVID initiative called Recover. So I apologize if I did that fast. I talk fast, but I'm nervous, so I'm trying to slow down. But I want to get on to the actual time of we can listen to them. And I think we're going to start off with Philip, followed by Gabriel, and then Dr. Peluso. So thank you all, and I'll be back.
Next, we're going to hear a testimony from Philip Chauvin about living with HIV and long COVID. The reason why Philip went ahead and pre-recorded his statement, it's because of the unpredictable severity of his symptoms. He is with us and he will be with us for the Q&A. But in the meantime, we're going to present a video where he's wearing glasses with a gray background, and he's wearing also a gray sweater.
Hi, my name is Philip, and I'm a survivor of 2 pandemics, HIV and COVID. I was infected with HIV in 1983. I went on to develop full-blown AIDS 10 years later. Then, in March of 2020, I was infected with COVID. Subsequently, I developed long COVID, and I've been sick for the last 2 years. In both situations, I was infected very early, before there was any conclusive evidence of what was happening and how the viruses were spreading. I'd like to talk about how I see the 2 pandemics intersecting in my life. In 1996, I was hospitalized with pulmonary Kaposi sarcoma, an AIDS-related lung cancer. The care I received in the hospital was so inhumane that I checked myself out against doctors' orders. I went home expecting to die. Fortunately, the triple cocktail of antiviral medication was released at the same time, and it saved my life. But everyone that had had Kaposi sarcoma in their lungs before me died. I was the first in the generation of survivors, but my entire social circle had already died. A friend of mine got COVID and passed away just weeks before the vaccines were released. This loss compounded my already existing trauma. I was tormented once again with the memories of the friends that had died of AIDS before the antiviral drugs were released. In March of 2020, I was infected with COVID. I had already lost my right lung to Kaposi sarcoma. Now my left lung was inflamed and I was gasping for air. At the emergency room, I was once again treated like I had leprosy. I was turned away because there were no beds, and again, I went home expecting to die. In the last 2 years, I have seen dozens of doctors. I have been accepted into the post-COVID programs at both NYU and Mount Sinai. Everyone has been very compassionate, but no one has offered any recommendations for treatment other than physical therapy. And physical therapy may be doing me more harm than good. The doctors don't seem to understand that when I exert myself physically, I suffer from post-exertional malaise. It's as if my battery is suddenly empty and it needs to be recharged, and that recharging could take 48 hours. I've been diagnosed with dysautonomia, a dysfunction of the automatic nervous system. In simple terms, my brain is not sending the proper signals to the organs in my body. The normal in and out of my breathing is irregular. My heart rate is erratic. I have migraines, urine retention, swelling in my feet, pain in my upper back and neck. I'm extremely lightheaded and dizzy, often with vertigo. I have tremors and muscle spasms. My sleep is segmented. My digestion is either too fast or too slow. I have been in bed with the curtains drawn for 6 months. I only leave my apartment when absolutely necessary. All of my doctors keep referring to my original case of COVID as mild because I was not put on a ventilator and my original symptoms only lasted 1 week. This terminology needs to change. When someone is sick for 2 years, there is nothing mild about the condition. I don't want to die, but I can't call this living. 2 years ago, I was doing laps around Central Park. Today, I can't walk up a flight of steps without feeling faint. I live between my chair and my bed. When I stand up, I feel as if I'm falling down. The tremors in my hands betray the buttons on my shirt. The food on my fork often does not make it to my mouth. I don't recognize my own signature. The letters seem to be falling down. In addition to dysautonomia, I have been diagnosed with ME/CFS, myalgic encephalitis, chronic fatigue syndrome. I'm relieved to have the diagnosis, but frustrated that after 35 years of research, the medical society still knows nearly nothing about the disease. During the AIDS pandemic, I took to the streets with ACT UP to demand funding for AIDS research. I learned that a voice is a powerful tool. It can change the way people think and act. Today, I find myself in a similar position with long COVID and ME/CFS. I am fatigued and lightheaded and dizzy, but I have access to some of the leading medical authorities in the country, and I am compelled to fight for respect, research, and funding every time I meet with my doctors.
Wow. That was really powerful. My heart just goes out to Philip, just to keep showing up and telling that story. I'm sure all of you were moved by Philip as I was. A couple things stood out for me, and I'm glad he's going to be with us later. He ended with, he keeps asking for respect, research, and funding. If you notice, respect was first. It's the humanity and care that we are talking about. It's the humanity that we deserve, however we have to show up. And it broke my heart to hear Philip say he went to the hospital and had to go home because no beds, or he wasn't getting listened to, or folks didn't take him seriously. And we have to do better in our healthcare fields, to bring the care back to healthcare. And I want to also say, one of the things Philip talked a lot about that I think our healthcare and our movement misses now that we're having to navigate aging with HIV and long COVID and whatever other chronic conditions we might have, is that we still want a quality of life that we enjoy. Philip said he was running laps 2 years ago, and folks sometimes will be happy to just keep giving us a pill and not caring about our quality of life, but we do get to choose and decide what kind of quality of life and that we want. And it's as important to us as the health care, because it allows us to have that quality of life. And one of the other things I thought about too, sometimes we're forging new ground, y'all. Y'all are educating the healthcare providers because we're showing up with things that they ain't seen before. And I want to tell you all to trust yourselves. They haven't seen it, don't want to admit they don't know, and trust yourself. I'm so proud that Philip persisted and still continues to persist. And unfortunately, we're having to educate providers about who we are and how we're feeling, and they don't get to tell us. So I want all of you, I know our HIV system sometimes does not always really it says they want us to be, self-serving and determining, but it's very patronizing sometimes and paternalistic, and we must manage our own care. And I'm hoping by conversations like this that we are more aware of the kinds of conditions. Philip might have described something you're feeling and you brushed off because the doctor didn't take it seriously. And I want you to know you matter. Respect for you and your humanity comes first. And if that doctor doesn't address it, change doctors, okay? So I respect research and funding. I just love that at the end, what he said. So Philip, we can't wait to hear from you later. And now y'all know who Gabriel is. We'll bring on Gabriel.
Hi, thank you for that, Vanita. That's really well summarized. Yes, Philip's testimony is super moving. I don't think he's going to be with us. I think that's just part of the recording, but yeah, he's one of my dearest friends, and he just put words to so many things so succinctly, very quickly. To say something about me, I am Gabriel Sanemeterio. Like Vanita said, I'm the co-founder of Strategies for High Impact and Long COVID Justice. I been living with HIV for about 14 years. I seroconverted when I was around 28. Not too long after, I probably contracted Lyme disease, but I didn't know it. So the diagnosis didn't come until 2011 when I was really, really sick. After that, I got treated. Then something that I don't usually mention in my story, but it did happen, is in 2013, I was diagnosed with Hep C. I was treated with interferon. I cleared it. I'm very grateful. But I say all of this just to make a point that I am no stranger to a post-viral reality. You know, I've had several infections that have been very serious and disabled me. And today I have a diagnosis. I live with a diagnosis of myalgic encephalomyelitis, or ME/CFS, and fibromyalgia. It was many years that my health was declining, and that doctors just kept saying, well, you know, it's going to take time. You just seroconverted. Oh, you know, it's just going to take time. You just got treated for Lyme. Or I used to be a hairdresser and I no longer can do it because it's too physical. A lot of my pain and fatigue was also explained out of my profession, right? It's like, well, you stand all day. Well, you don't have the right chair. Well, you know, it was like that. And then it was like, oh, well, you were on interferon, so it's going to take a while to feel better. And meanwhile, I was not getting well. Like Philip mentioned, I was also being told that I needed to get my heart rate up, that I was a young person, that I needed to do things and just push through it. And that wasn't the case. Eventually in 2017, when I got diagnosed with ME/CFS, I learned that I actually need to pace myself. And that's what radically changed my life. Stop, rest, pace is the best managing technique that I've found for my ME/CFS. It does more. I mean, I do take medications that help, but I really recommend it. And so if you notice that your fatigue increases or gets worse, or your symptoms are exacerbated by physical, mental, or emotional exertion, I recommend that you look Stop, Rest, Space. I know that they're going to send an email follow-up. So there's going to be some of these resources in it. I also want to thank the Reunion Project for keeping up virtual programming, which is so important to keep us connected, to keep us informed, and to keep us safe, because COVID's still making the rounds. One of my dearest friends right now has a COVID reinfection. I mean, it is, you know, while it's being minimized, and it's still around and we're still at risk. So, not to scare you, but to remind you, I'm just going to share my screen. For instance, we have some resources on our website, you know, like this practicing inclusion in the time of COVID. And that's exactly what the Reunion Project is doing. You know, it's inviting us to ask, like, who is missing? Why are they not here? And how to have these hard conversations, right? Like, well, I'm immune compromised. Like, you know, let's talk about COVID safety. So you can check these out on our website. Like I said, it will be sent to you in a follow-up email. But wearing masks is still a big thing, right? We have different layers of protection that are available to us. Not all of them are perfect. And so in trusting ourselves, knowing how we feel in our bodies is very important, whether it's validated by doctors or not. They don't know everything. They know a lot, but they don't know everything. And taking care of each other. How do we show up for others? How do they show up for us? We've seen a significant value shift when, you know, we were all masking. Two-way masking works well. It is more protective than the option that we have now, which is you do you assess your risk, which marginalizes us as per people living with HIV or people living with disabilities or immune compromised, because we cannot go out and live our lives. By the way, I got COVID a year ago. It was just my COVID-versary. And I got it when people stopped masking in the subway. So I kept my practices of mitigation, but everybody else changed their behavior around me. Not blaming them, but it was something that really changed the environment, and I got COVID. And since my symptoms had gotten worse, I'm cognitively affected more. The severity of my symptoms varies greatly. So I'm learning again to stop, rest, and pace. Additionally, I became pre-diabetic. So I encourage you all, if you have, and Dr. Peluso will touch on these things, I'm sure later, that if you have some symptoms such as chest pain, shortness of breath, or like, you know, seek immediate medical attention. You just never know. They could be fatal. And if not, it could be something that is more chronic and long-term, and you still should seek medical attention. If a doctor doesn't know, move on to another doctor. It's just the post-viral illness realm has been really underfunded and under-researched. None of what I'm saying is actually medical advice. Again, follow your medical professionals or Dr. Peluso. I'm just offering suggestions and anecdotes. There's been a big effort to sort of discredit masks, and this article is going to be distributed. You know, there's decades of engineering and occupational science that went into developing masks and creating standards for masking that precede this pandemic. So the few studies that have been used to discredit masking just because people are tired of wearing masks, they do not amount to actual evidence to discredit the use of masks. They work, they're not perfect. Therefore, we need to use multiple layers of protection, such as improving the air quality, wearing the masks, you know, keeping distance when we can, avoiding the indoor crowded places, limiting our exposures, getting vaccinated and boosted if you can, and, you know, testing, even though it's not as easy to access tests anymore. Testing should continue to be a good practice. And if you feel sick, stay home. If you're not sure, if you think it's allergies, still stay home. Take care of others and take care of yourself. Not all masks are the same. This is from the People's CDC. They're a great resource. As you can see, N95s are the best. KN95s are better. The rest are less effective. But we should also give grace to people who cannot wear an N95 respirator due to a medical condition. The thing is, if we all wear masks, it's more effective. So they could wear a surgical mask while we're wearing other masks that are of higher quality to protect them and to protect ourselves. Okay, so by the way, under the ADA, people with HIV, we are protected and we can ask for reasonable accommodation, which is that people mask around us. Our medical providers, our service providers, our caseworkers, our case managers, we can ask them to mask. There is a federal, legal precedent, and the People's CDC has a great webinar on all the details about the ADA and reasonable accommodations, masking as a reasonable accommodation. That will also be sent to you. I encourage you to look at it and protect yourselves. Don't be afraid of asking, or just because other people aren't masking, you don't either. Service providers and community organizations, you should be providing N95 masks, high quality masks for everybody. You can buy them in bulk. There are great discounts. A lot of people don't mask because the cost is prohibiting. But just like condoms, just like lube, if we want to prevent disease, we need to provide masks for free. And about, the question of if or when one gets sick, one should have different, plan for the worst and have plan A and plan B. When I got sick with COVID, I did get a chance to take Paxlovid. It existed, it was available, but I planned for a 7-day course of Paxlovid and disease. And it turned out I experienced a rebound. My rebound was fully symptomatic, and therefore I was sick for over 2 weeks. So building relationships and talking to people, finding out who can be of support is very important. This work is called pod mapping, and pod mapping was created by Mia Mingus. She's an educator and trainer, and used this format for transformative justice, but it's been adapted for other types of care and mutual aid. I found this from the Autism Society of Minnesota, which really explains what pod mapping is. This is not making a list of your friends. This is really seeing who is out there in your network, all the way from friends to neighbors, acquaintances, service providers, medical providers, etc. And this is what the pod mapping looks like. We have an in-depth look at the worksheet on our YouTube channel of Long COVID Justice, but just very quickly, I'm going to show you how this is done. In the center, well, you should ask these questions, right? Like, people in my pod, what are they good at? Not everybody is good at emergencies. So who's a good listener? Having moral and emotional support is really important. Remember the days when it used to take a long time to get an HIV test back. And there were days when it took a really long time to get a PCR test for COVID back. So who is there for you to just listen or to support you during those wait times? Or if you're sick and you can't access a test and you're just having to, isolate, who's going to be there for you in that way? Additionally, who can bring you things, who can pick up your medications? All those things have to be considered. Also consider what you can do for others, right? It's hard to accept help, and it's hard, and it's just as important to consider who we can give help and how we can help. For the pod mapping in the center, it's really easy. There you go. You should be in the center, and in the circles, you should put names, specific names of people. Now, I would suggest that you do this with somebody else, because this can be really triggering. These black bolded circles are for the people who are closest to you. For most people, that's just 1 or 2 names. And with the losses that we have experienced, many of the people who would be in these circles are no longer with us. So it is advisable that you do this with somebody else, just to have that kind of support. here they go. These are the people closest to you. In the dotted circles, you have people who can move in and out. These are acquaintances, neighbors, other people who can do you a favor, and not necessarily, you don't have to be like super close to them, but be strategic about building these relationships and having the conversations, the hard conversations. What can you do? What can I do for you? What would you like me to do? I have to say, like, for me, it was hard to accept help when I had COVID and I was really sick. And the only hot meal that I had is because somebody sent it to me. I was too sick to think about hot meals, but this person insisted, no, you should have a hot meal. And he had it delivered for me. And it's the only hot meal I had the entire time I was sick. So in the bigger outer circles, you have your community groups, networks of other networks of support, and your medical providers who can come in for emergency or very specific services. So mapping out really who is there for you and who can be there for you, given all the diseases that our communities have faced, not just COVID, but there was also Mpox and RSV and influenza. There can be many things. So this is helpful for other things. I really thank you for listening, and I look forward to your questions. Thank you.
Gabriel, that was so good. Thank you so much for that. I love this pod mapping, y'all. This is really, we build community we do this informally anyway, but to really think about it intentionally, I think is a really cool idea. We've been doing this, Black communities, every community has done this to how we take care of each other. Sometimes we've lost some of that because, we've had to move away or we've had to work around the clock, but really a couple of years ago, we put out a video around election season and, getting your pods together and your support and all of the things you needed in case something happened. And it was from a safety standpoint. Well, I think and being ready from a safety standpoint, I think the same thing is true from a health standpoint, an illness standpoint, and or inflation. We had parents who couldn't find formula, right? But yet we have guidelines that told them don't breastfeed, right? And so how were we taking care of each other? So thank you for that. And I have this one practice I've never told anybody. If somebody posts on Facebook, and let's be real, after people start coming out with COVID who also living with HIV, there was stigma and shaming behind this. And I was on one call where someone said he got COVID and people went, how did you get it? What did you do? And I felt like the days of HIV when people were asking us that, well, I did everything right and I don't know how I got it. Folks were trying to explain, and I called it out because we have to be careful not to do shaming, because COVID is airborne, you know what I mean? Whether HIV, COVID, or any other illness, not to shame. But what I do when I do see people announce they have COVID on Facebook, if I know them, I'll reach out to them, and I'm a good person for sending an Uber to them in terms of, you said that about a hot meal. I always feel so powerless, but one of the things I can do is send a $30 Uber or something to have that person, whether it's feed the kids or something. And so it's how we practice collective care. And I never say that to anybody, but it is what I do. Gabriel talked about stop, rest, and pace. Woo! We need to just stop on that for a minute, because I don't know about any of y'all, but if I need to rest, I think I'm lazy. It's changing the mindset of what production means, but stop, rest, and pace. And that means honoring our bodies. It means honoring our time. And thank you for saying that, because I'm gonna go home and put it up somewhere now too, because stop, rest, and pace was really a good one. And I've had to really kind of listen to that just from a mental health standpoint, as well as a physical health. And, I mentioned to you all before about trusting yourselves. I caught HIV, I acquired COVID at the end of probably 2021, when I got together with 9 people and we were all vaccinated, and we thought, okay, we had masks, but when we got into space, we were so happy to see each other. And then 8 out of 9 tested positive for COVID. So we got a chance to go through this together and things, but I felt like I had COVID last December and my home test showed negative. You know what? I canceled a trip and everything because I paid attention to my body before I paid attention to that home test. So I don't know whether it was right or wrong, but I know how I felt, and I felt like I needed to protect myself and others from not going out. So that's what I mean, that you all listen to yourselves. Masking has become very political, and this is life and death, y'all. Don't get caught up in the culture wars of, you know, certain parties using masks as a red meat to enrage voters and things. Masking is about saving our lives and what else we can use to keep ourselves and our health. I have a great nephew that's 2. My job is to keep him safe. Right? And his parents, all of us are thinking that way. And we live in a new era now, y'all, in this post-pandemic world that, you know, we did a retreat and one of our staff didn't want to be vaccinated. So the rest of the people didn't want them there. So we're having to navigate a whole lot of new situations with family. Do you get together? Who's vaccinated? Who's not? And I'm not here to do any vaccination shaming or anything, but I just want to say we have a lot to navigate. And so talking to each other, resources that Gabriel showed, I think are really critical to not only reading yourself, but share with someone else. I haven't seen anybody share COVID information in a while, like it's over. So I just want to say that thank you for that, Gabriel. Stop, rest, and pace. And we need to educate and inform and trust yourselves. Don't get into the politics of masking. Do what you need to do for you and your family. And with that, I'm just so excited. Dr. Peluso, you know, we eat doctors for breakfast, but we're going to be gentle with you and come bring us some information.
Hey, can you hear me okay? I think I need to get permission to share the screen. There we go. All right. Can you see my slides? Hey, everyone. It's such a pleasure to be here to talk with you today. My name is Michael. I'm an infectious disease doctor, HIV provider, and COVID and long COVID provider now at UCSF in San Francisco. I'm originally from the East Coast, but moved out here about 7 years ago, really with a focus on HIV and our HIV cure program. I'm part of the efforts to try to find a cure for HIV. And then when COVID happened, we basically you know, we sort of knew from prior experience that lots of infections are more complicated than they are initially framed. And, you know, on TV, when this was framed as a 2-week illness and everybody would be 100% back to normal, we knew that that almost certainly wasn't the case. And so we decided to try to build a program to understand what happened to people after they got COVID. And soon started to see a lot of people who were experiencing long COVID, you know, really at the very beginning in April and May of 2020. And then, you know, because of my background as an HIV doctor, was really interested in how COVID was affecting my patients with HIV, and have done some work trying to understand sort of the intersections between HIV, COVID, and long COVID. So anyway, I've prepared some slides. I actually edited my slides a bit during Gabriel's talk because I thought it was so great, and stole a couple of things from him. So I'm excited to share all this with you. So yeah, so you know, we're 3 years into this, and I was sort of, I guess I should have known this, but I used to be one of these people, especially with a lot of family and friends in New York, who at the beginning of the pandemic was kind of tracking the case rates every day. And I went back to look at the curve yesterday as I was preparing these slides, and was surprised to see that they actually stopped reporting case rates in March of this year, which was, you know, I don't know. it's actually quite hard now to figure out how much COVID is spreading on a daily or even weekly basis, whereas previously there were lots of resources to do that. The good news is that there are still reports of hospital admission rates and death rates, and those have really declined. At the lowest rate since the beginning of the pandemic. And so I think that that's something that's good news, and, is largely due to the fact that there's so much now pre-existing immunity among all of us, including, vaccine-induced immunity from prior infections, and the combination of those two things in people who've been vaccinated and also have had COVID is particularly potent and protective. So sort of the silver lining, we all went through all of this to get to this point. So it's hard to feel great about that, but it is good news that overall things are looking better. And, there are some positive news headlines. Death rates are low. Doesn't mean that people don't still get sick. Doesn't mean that people don't still land in the hospital. The vaccines have been really wildly effective. At the beginning of the pandemic, when they were rolling out the vaccines, I was talking with some colleagues here, and we were saying, so like, how effective would the vaccine need to be for you to be excited about getting it? And I basically said 30%. Like, that's really low. Because that's sort of the headspace I was in at that point. I was so worried about this, and they obviously turned out to be, multiple times that in terms of how effective they were, which is great news. And then, now we actually have treatments that don't require most people to have to go to the hospital and get admitted, and they're pills, and they work really well. I actually met the chemist who designed Paxlovid a few months ago. Really, really nice, very humble guy who, his life's work basically ended in the design of that molecule. And it's amazing that it exists and is, relatively accessible, but still a lot of barriers and sort of a lot of self-imposed barriers, in my opinion, by the healthcare system, that people are really hesitant to prescribe it. I'm not really sure why. But those are all good things. So is COVID over? I would say no, but I think a lot of people are sort of questioning this. And so I think it's important to sort of address why COVID's not over. So COVID's still risky. There are ways that we can protect ourselves. There are ways that we can deal with getting COVID, but they're not perfect. Vaccines, this is not on the slide, but vaccines used to prevent all infections in the first few months, which was amazing. That quickly changed with Delta in the summer of 2021, but they still do protect very well against severe illness, and the updated vaccines probably do a better job of that. And I think there might be more updates this fall. And the treatments are pretty good. Particularly Paxlovid is very effective and has likely saved a lot of lives. That being said, they're not perfect. It is not a be-all end-all cure. And so there are a few points to make. First, you can take Paxlovid and still get pretty sick. And I think as more time goes on, that will continue to be the case. The molecules in Paxlovid are similar to molecules in HIV meds. They're protease inhibitors. So, those molecules came out in the late 90s and early 2000s for HIV and are still used. but we know that eventually viruses can develop resistance to these things. So this treatment may also not be around forever. And then there's this really important point that has been brought up a couple of times about rebound symptoms. And so I wanted to spend a minute and talk about that. So what that means is that a person with COVID feels like they are getting better, and then maybe feels totally better. And then a couple of days after they're feeling well again, they feel sick again. And this got a lot of attention with Paxlovid, because people were attributing feeling better to Paxlovid, and then Paxlovid is only 5 days right now. And so they would feel better, you know, for a few days, and then they would feel sick again. And so in the studies, there's somewhere, you know, the studies say that somewhere around 5 to 10% of people will experience that. In my experience, it seems like more, but I don't have hard data to back that up. I think it's probably closer to 20%. So that means, you know, for every 5 people who get COVID and take Paxlovid, 1 person would have rebound symptoms. But something that is really important and that we actually forget is that you can have rebound symptoms even if you don't take Paxlovid. And so I remember very, very well the beginning of COVID, of the pandemic, where a lot of people would describe these illnesses where they were healthy, they got COVID, they got sick, and then they felt better, and then they felt worse again, and then they felt better. And so that's definitely a pattern that can happen regardless of whether you take treatment. It may be more likely if you take treatment, but it's something that we all need to anticipate, you know, if we get COVID again. So that's, you know, this rebound thing is something that people worry about and I think is really important. And then the second thing I would say is that even though acute COVID may be slightly less risky than it was at the very beginning, the long-term consequences are very real, and long COVID is still happening despite people being vaccinated, having pre-existing immunity, and having access to treatment. Again, it's probably happening less, but I still know, I run a long COVID program. I know lots of people who got long COVID related to infections in 2022, in 2023, despite taking Paxlovid, despite having 4 or 5 vaccines. So it's something that I still worry about. And personally for me, the long COVID concern is an even bigger motivator than the sort of front end of the illness at this point. But everybody has different opinions about that. So what is long COVID? Many people are probably familiar with this by now, but when COVID happened, we thought everybody was going to fall into this category that's shown on the left side of this slide, where people got COVID, they got sick, and then they got better, as indicated by this person with the check mark next to them. But the reality is this other line in yellow, which is that there's this long tail of recovering from the initial illness that in some people can be quite quick, but in other people can be quite prolonged. And some people even develop symptoms later that are potentially related to COVID. So a month later, 2 months later, impossible to know for sure, but certainly possible. And this is called long COVID. And so the definition of long COVID that I like is physical or mental health symptoms that don't go away in people who had COVID. And this can really happen in anyone who's had COVID, even people who are vaccinated, even people who get treated. There are all these like technical names for long COVID that various government agencies have created, but my preference is to call it long COVID, which is what actual people and patients call it. And so I think that that's gaining a lot of traction, actually. There are all sorts of symptoms. Again, you might be familiar with these. These are some of the symptoms that we see most commonly in our research program here in San Francisco. Probably the most common symptom is fatigue. So people feeling extremely tired. Sometimes that comes along with what Gabriel mentioned, post-exertional malaise, which I'll talk about a little bit. People can have very significant issues with trouble concentrating, I know multiple people who've had to make accommodations at work or even change their job because of that. Some people have a lot of really physical symptoms, so chest pain, the sensation that their heart is racing, shortness of breath, even when they're not really exerting themselves. But the symptoms differ between people, and there's no kind of single set of symptoms that you could say this is or is not long COVID at this point. The other thing that's really important is that people often have good days and bad days. So, or good weeks and bad weeks, or good months and bad months. And so the symptoms can come and go within a person. People often feel very hopeful when the symptoms have gone away. Sometimes they stay away, sometimes they come back. And what we see kind of across everything is, and everyone, is that the symptoms have an effect on quality of life. In some people, the effect is mild. In some people, the effect is more severe. But any effect on quality of life is not really where we want to be. So it's, I think, a big problem. So a lot of the work in the last 2 or 3 years has been trying to understand risk factors for long COVID. And so I'll show some of those risk factors, but this is not to say that long COVID only happens to people with those risk factors, right? Anybody can get long COVID, but it's more common in certain people. So it's definitely more common in cisgender women than cisgender men. There's not a lot of data on transgender people yet, but hopefully soon. And that's really important. We don't know why that is. And it's actually the opposite of acute COVID, right? With acute COVID, men overall did much worse, much more likely to be hospitalized. So it's the opposite pattern. And we know that there are a lot of illnesses that are more common in women than men, but we don't really understand biologically why. So there's a lot of efforts right now to try to understand that, and I think it's a really important question. Generally older age, what I mean by that is kind of middle age and beyond, seem to be more affected than people who are like very young. But again, I know plenty of people in their late teens or early 20s who are experiencing long COVID. Seems to be most common kind of in the age bracket of like 40 to 65 though. We know that other medical problems, especially having diabetes or being overweight or obese, increases the risk of long COVID. We don't know why that is yet either, but that's definitely an important factor. We know that people who have less access to financial resources and healthcare resources are unfortunately at higher risk for long COVID. These are the same groups that were at higher risk during all of the other phases of the pandemic, and we think have been hit hardest by long COVID as well. And that's especially problematic because these communities often have the least access to accommodations at home, at work, financial accommodations, work accommodations, disability accommodations, just less access. So a lot of people who disparage long COVID, which those people still exist, will try to make an argument that, you know, people with long COVID are just people who have time to feel unwell and have the resources to complain. And there's no data that bears that out. Like I hear that all the time from people who don't like that this problem exists, but there's no data to back that up. Being vaccinated is definitely protective. And so I advise all of my patients to get vaccinated, not just to prevent them from getting super sick during acute COVID, but also to decrease the likelihood that they would get long COVID. It's probably true that the older variants caused more long COVID than the Omicron variants. Really hard to say for sure because vaccines and treatments were not available back then. But there could be some characteristic of the variant that makes a difference. And then just, you know, there's this point about severity of the initial infection. And it is true that people who are more symptomatic early on, people who are sick enough to warrant hospitalization, are probably more likely to get long COVID, but the vast majority of people who have long COVID don't fall into that category. They had what would be, and I put in quotes here because of comments that were made at the beginning, what would be called mild infection up front. That's not to say that their disease course has been mild. Obviously it's not, but they were not, in the ICU on a ventilator during the first 2 weeks. And that's what, when clinicians talk about mild COVID, that's really what they're referring to. The terminology is not what it could be. So I wanted to talk a little bit about HIV. And so I think HIV is probably a risk factor. So being HIV positive is probably a risk factor for long COVID. We did an initial study a couple of years ago here in San Francisco, looking at 40 people with HIV and 40 people matched. So that means that the people who were HIV negative were the same age, the same sex as the people living with HIV. The people living with HIV were all on meds and suppressed and doing well. And we found that asked the same questions in the same way about symptoms, people with HIV were 4 times as likely to meet criteria for long COVID. That was actually really shocking to me, that it was that high. And so that brought a lot of attention to this issue. There's this really important paper by Grace McComsey's group in the Midwest that used health systems records. So looking at tens of thousands of patient records. So my study was 80 people. This is like 50,000 people, huge number. And they basically found the same thing. They were trying to replicate what we saw to see if they could show that it was true on a larger scale. And they found that people with HIV were more likely to have long COVID symptoms and also have other medical problems after COVID compared to people who were HIV negative. Vaccines, being vaccinated prior to COVID was highly, highly protective in this study. And it's not officially published yet, but it's gotten a lot of attention and I think is the most important study on this topic. And then Annie Antar, who's at Johns Hopkins, and I, obviously we're both HIV researchers before COVID, and we wrote recently this piece on long COVID in people with HIV, which kind of summarizes what is currently known. And so if you're interested, I think it's freely available if you just Google it. We can also send it around. So why might people with HIV be at higher risk for long COVID? We don't really know, but there are all sorts of reasons that we could speculate, and some of them are shown here. So generally speaking, people living with HIV may be more likely to get sicker at the beginning of a COVID infection. They're also, we know that people living with HIV have higher rates of other medical problems like heart problems, diabetes, etc. And then, the other thing we know is that HIV, even when treated, still causes kind of this smoldering inflammation in a person's body. It doesn't necessarily cause problems. And obviously, as you all know, people with HIV now have equivalent lifespans as to people who are negative. But that inflammation could kind of make worse whatever is driving the long COVID symptoms. And so that's something that we're trying to look into and understand a little bit better now. So a lot of interest in this area, because what this ultimately might mean is that the approach to a patient who's living with HIV and also has long COVID might need to be a little bit different because of factors like this. So, in terms of COVID in 2023, I think the world is trying to move on. In my opinion, that means that people are trying to be in denial, but COVID's still spreading. We know that's true. I have a friend who got COVID on Monday, first time, took all the precautions and still was unlucky. I think there's this growing sense, I at least feel this as somebody who's very cautious, is that everybody's kind of on their own. I really don't like that. But that's the reality. Because of that, some people are really frustrated and may feel helpless. And people with long COVID are, at least some of them are really struggling. So where do we go from here? So I have, I think, 5 points that I want to make. So the first, and I think this is all in alignment with what's previously been said. The first is that it's really important to take the approach that's right for you. So just because other people have stopped caring about this doesn't mean that you need to stop caring about it. It's okay to ask people to mask. I do this every day. It's okay to ask people to test. I had, last week, one of my closest childhood friends came to visit in San Francisco. And I was like, I need you to do this COVID test before you come. And he was totally fine with it, and it's still important to take precautions, and, that can be trying to do stuff outside. It's nice outside. I think a point that I like to make is that it's safe to assume that if you were doing something in a group of like 10 to 20 people, that it is likely that somebody in that group is shedding COVID from their nose. And they may not have any symptoms. It's not their fault, but it's okay to take precautions because of that. We have to remain cautious. I think we need to mention being the only person on a plane who is wearing a mask. I am the other person on the plane wearing the mask. It's really hard to not give in to peer pressure, but I just sort of like made this agreement with myself that I do not care what other people think. And so I wear my mask, and I am often like very self-conscious, but on this I am not. And then you have to make the decisions that are right for you. It's okay not to do these things too if you don't want to do them anymore, as long as you're aware of the risks to yourself. And I think as long as you're trying to be aware of the potential risk to other people. I had a person who wants to enroll in our research study who just had Paxlovid rebound and is like frustrated with me that I said that they can't come in. And it's like, we need to protect everybody. And so, yeah, I think, just being mindful of that, which I'm sure everybody on this call is. Protect yourself. So vaccines are still the best way to avoid long COVID, even if you do get COVID. There are some CDC resources that kind of show what people are eligible for and when. It's kind of hard to navigate. What I would say is make sure that if you're trying to stay up to date on your vaccines, make sure that you got at least one vaccine after September of last year, when the bivalent ones rolled out. You may be eligible for another one, which would be fine, but there are probably new vaccines coming in a couple of months. So depending on your own personal risk, you might want to wait. I took this image from Gabriel. I really like this image. So it's okay to ask your provider to mask, but do not get mad at your provider if they ask you to mask, which happens to me. So I ask all my patients to mask in clinic. I have like an immunocompromised parent and a young child. And sometimes people get annoyed, and it's like, it's a two-way street in my opinion. So, but I think it's okay to ask people to mask. It's very important to have a plan. If you get sick, it is likely, despite precautions, that we will all get COVID at some point if we have not had it already. And if we have had it already, it's likely that we will get it again at this point. So a plan for that is to have some home tests. These are much harder to get now that the government kind of changed its policy. You can buy them on Amazon in bulk, and there may be local resources to access them. Know how to schedule a telehealth appointment with your doctor. Please don't go to your doctor if you're actively sick without calling them before. It's like really important to let people know. And then I think we should all be asking to get treated if we have COVID. A lot of doctors don't offer it spontaneously, and I found that people really need to be aggressive in asking for it. And then some other points that have come up on this call is it's actually quite common that a home test is not positive right away. So this friend that I know who got COVID on Monday, had symptoms on Sunday, tested negative Monday morning, and then was super positive Monday night. And so it took basically 3 days. Sometimes it takes even longer. Sometimes it doesn't turn positive at all. If it doesn't turn positive at all, it may not be COVID, but there are lots of other things that are circulating now. And I mean, you know, COVID's bad, but the other ones aren't good. So you can have non-COVID illnesses that you don't want to give to other people and that are still problematic. And, you know, it's important not to ignore your symptoms. So if you don't feel well, you know, be careful. The antivirals work really well. You know, I'll share the slides and you guys can look at this, but this is a summary of the paper that, you know, showed that they work really well. I basically recommend that all of my patients living with HIV get treated. I think it's a sufficient enough risk factor. And so I try to get everybody treated, and I think it benefits for the acute infection, and I think it benefits for long COVID. So this study came out in the spring showing that people who get treated with antivirals for acute COVID are less likely to have complications in the 3 months after COVID, after their initial infection. And so I think this is an equally compelling reason to seek treatment up front, even if you're not worried about getting super sick up front. So what if you have long COVID? You know, I hope that many clinicians have changed their tune over the last 3 years and are more knowledgeable of the diagnosis. I think there's broad consensus that this is like nobody should be debating anymore whether this is real. Like the time has passed for that. There are massive efforts to understand this. Here are some things that are helpful to say to frame it for someone. So if you think you have long COVID, you might say, since I had COVID, I am experiencing fatigue, headaches, whatever symptom, which I did not have before I had COVID. That should be a sort of a light going off in someone's head. Or my headaches are much worse now than they were before I had COVID. Both of those are sort of the framework that clinicians are thinking about for long COVID. It's okay to ask your doctor directly, do you think I could have long COVID? Sometimes people just need prompting. And then another thing you might say are there any tests that you think I should do to make sure there's nothing else going on? Because the long COVID symptoms that people experience can be caused by other things. And it's important to know that there's not something else going on. I think Gabriel mentioned that too. So it's really important to work with your doctor. You should make sure that your health screens are up to date, that you've had your regular cancer screenings, that you've had your regular diabetes screening, that you've had your cholesterol screening, that you're undetectable, that your T cells are looking good. Make sure you rule out other stuff, and your doctor can help you do that, but don't go overboard. I have seen a lot of harm come to people from way over testing. Often the tests are normal. Most commonly they are normal. It's okay if they're normal. It doesn't mean that the symptoms aren't real. It just means that we haven't figured out the right test yet. So, there's sort of a balance here. I think it's very important to remember that physical symptoms and mental health symptoms are very much intertwined. That does not mean that the physical symptoms are not real. It just means that they can be worsened by mental health symptoms. And then also like feeling badly and not knowing what's going on can make people feel worried or anxious or depressed. And so that's actually something that can be dealt with. And so I try to encourage people to take care of their mental health too. It's important to be proactive about asking about vaccines and treatments. There is a diagnostic code for long COVID now, so you can ask your doctor to put it in your chart. And an important point that often comes up is like a long COVID diagnosis clinically does not require a positive test. You just have to think that it's likely that you had COVID. I'll speed up because I know I'm probably gone over time, but it's really important to not try to treat long COVID on your own and to find a provider who can support you. There are efforts now to build up infrastructure for this. The infrastructure right now is like wholly inadequate, and everybody recognizes that. There will be centers for excellence for long COVID that should be launching early next year. They probably got many applications, but hopefully these will open up. I'll talk about the exertion stuff in a second. And then it's important to know that clinical trials are coming. They're starting via Recover, they're starting via local programs. And I hope that they will be inclusive of people with HIV. All of the clinical trials that we're doing at UCSF will be inclusive of people with HIV as long as they're on meds. Gabriel talked about post-exertional malaise, so I won't belabor this, but it's just important to realize that some people, not everybody, but some people can have worsening of symptoms with exertion, and sort of exercise therapy and some very active physical therapy is actually contraindicated in those people. So if you are a person who experiences that, you need to do what Gabriel said and take this pacing strategy. And there are some resources on this slide. And I stole Gabriel's catchphrase here, which I really liked. It's also important to stay up to date on everything else. So stay up to date on your other vaccines to protect against other lung infections. There's this new RSV vaccine that will be rolling out. There's updated pneumonia vaccines, which you may be eligible for. There are lots of guidelines on this, but your doctor is probably keeping track of what you're due for. And it's important to stay up to date on vaccines that are not just COVID vaccines, because these other infections can still knock you down. Long COVID is part of this web of other what are called infection-associated chronic illnesses. These conditions like chronic fatigue, post-Lyme, and all sorts of other symptoms. I put POTS dysautonomia twice, I'm not sure why I did that, that have really not been well understood and have not been well funded for study. But there is some hope, and my last message is to have some hope. So last week, there was this amazing meeting at the National Academies of Science in DC. I don't know if anybody here attended that. That was the first ever meeting focused on these conditions. It was sort of set off by long COVID, but it had representation from all of these other patient and research communities. And so that gives me a lot of hope. These conditions have really been understudied. They're very stigmatized, and long COVID has generated a lot of momentum that I think will kind of lift up everybody in terms of figuring this out. And then I think there's also a lot of hope for HIV. HIV treatment is changing. It is continuing to get better. And people like me are still really invested in coming up with a cure for HIV. So this was a really nice review that was published last week, talking about sort of the intersection between HIV prevention, treatment, and cure. And especially now that the public health emergency has wound down, a lot of HIV research efforts are kind of ramping back up. And so I think there's a lot of hope on that end too. So just to end, what do we need to figure out long COVID? We need compassion for people with long COVID and infection-associated illnesses, and some humility that we don't really understand what is causing all of this. We need to listen. Doctors need to listen to patients. Patients need to listen to doctors and clinicians and also give them some grace, I think. And there's a lot of nasty stuff on Twitter that's really terrible, and I think is going to cause setbacks in the field, because there's just so much, social media can be so toxic. And then we need a lot of advocacy. We need advocacy for way more funding than currently exists. We need advocacy for clinical programs. A program like the Ryan White program to give access to people is really important. We need advocacy at the FDA to jumpstart some of these regulatory discussions, because it's really hard to get long COVID clinical trials launched because no one really knows how to deal with them from a regulatory perspective. We need advocacy for education programs to educate current providers about long COVID, and then to create a pipeline for people who will carry this all forward sort of in the next generation, which is really not happening at all right now. And then we all need to be patient with each other. Hopefully at this point, most clinicians are trying, maybe not all. And so hopefully you're all connected to people who are trying. And then we need a plan for the future. So I will end there. I'm sorry I went a few minutes over time, but happy to stick around a little longer as well. Thanks so much for your attention.
Wow, thank you. Thank you for that. Yeah, we need way more time for me to unpack that, so I'm not going to even try. But thank you for that. I like to do what's best for you, protect yourself. And I love the focus on mental health because I dealt with that a lot during the pandemic. But I want to bring our panelists back and see, we only have maybe 5-7 minutes for some questions. And Dr. Peluso, I wonder, somebody asked, is long COVID contagious? If you could just answer that. And this issue, is COVID respiratory, or is it go to all systems?
Yeah.
Or two I saw.
So there is currently no evidence to suggest that a person with long COVID could give COVID to someone else. By definition, they are outside of the window where it is known to be contagious. The reason that this question comes up a lot is one of the proposed mechanisms, like biological things that could be causing long COVID, is pieces of the virus persisting in a person. But it is not thought that that virus is contagious. It's thought that it's kind of like defunct and just causing trouble, even though it can't be spread.
And Gabriel, do you mind? I noticed you did respond in the chat about the respiratory nature, if you want to respond to that. And Heather, help me if you see a couple other questions while they're answering this.
Well, I think originally, people were getting respiratory symptoms, and that's where it's very common to have the virus enter the body, but it can attach to any tissue in the body and cause inflammation and problems everywhere. A lot of people have GI, like gastrointestinal, stomach problems when they have COVID. So in the beginning, it was very framed like a respiratory thing, but it's not exclusively.
Yeah, you're right about that. And I see a question, Shakina, do we have any studies on long-term survivors, long COVID and monkeypox exposure? I guess that the intersection.
I do not know if that intersection has been looked at. That is a good question. Gabriel, do you know?
No, I don't know, but I would think since Mpox is a type of herpes, that it would have long-term effects, although we haven't heard what those are, since it's also been understudied and under-researched, because it was perceived as something that was far away. Right now that it got hit home, maybe it'll get some attention.
Okay, and thank you so much. I want to just make a last ditch attempt, and if there's questions or anything from the panelists that they want to add, or if anyone has a question that they didn't get answered, to come off or mute and ask the question. But panelists, while we're waiting on that, is there anything you wanted to add? Oh, I see Terry Taylor's hand up. Terry, come on off mute and ask your question.
Good afternoon. Thank you for presenting. It's hard to find at-home COVID tests and at-home HIV tests. Can you guys drop some links in the chat or send them with the follow-up video and PowerPoint for this presentation in the email?
Yeah, there's a program called Take Me Home, right? That is giving HIV tests. They mail the HIV tests, but we'll do some research and send the links. But since the public emergency ended, the funding for free tests ended. So that's not a good thing.
And Dr. Peluso, I want you to, there was a message for you about who is doing research on long-term COVID and trans people. They'd be interested in any studies that come available. And they said a lecture with the Rust Belt CFAR Sex and Gender Scientific Working Group would find this topic interesting.
Yeah,
so you know what.
There isn't, so that within the National Recover Program, you know, which is a very large study of thousands and thousands of people, there's an effort to recruit trans people to have enough representation to actually answer these questions. And so that operates at a number of sites throughout the country. And so if you go to recovercovid.org, you know, basically in nearly every state there is a site. And then I'm not sure of other focused efforts on this, but looking at whether there are resources within the CFARs, I think is actually a great idea. So thanks for mentioning that.
No, thank you. And our time is winding up, and I really want to thank Gabriel, Dr. Peluso, and Philip, who isn't here. You all brought a perspective to this that was well-rounded from lived experience, personal experience, and from a scientific perspective that Dr. Peluso, I have to say, showed a lot of caring. I would put, if we were in another place, I might push back on you because our life equivalency is not equal to our peers. And I don't care what the data shows, it is not. And because I think people are, they're showing primary cause of death, their HIV is not showing up on death certificates that have a contributing factor. I just had a friend die from kidney failure, and on his death certificate was listed as natural causes, but he was living with HIV for a number of years. So I just believe that we do know we're 4 times more likely to have this. And yeah, I will be patient with my doctors, but I expect my doctors to also bring some curiosity to the table as well. I think it is a partnership and a group, well, not a partnership, but it is a relationship that says, you know, we are equal in here, whether with your degree or not. And sometimes that doesn't come across when folks, we're living with HIV, they assume we don't know how to take care of ourselves, or that, you know, we don't know how to take care of ourselves, or that we wouldn't understand stuff. And so there is this patronizing way that we're dealt with sometimes that I find very insulting and will change a doctor immediately. But I didn't know that at first. So I just want to thank everybody. And I want to take y'all back to the real focus of this webinar about how do we take care of each other in our communities. That COVID is something, the HIV community and other, that we're going to have to live with, and other comorbidities and chronic illnesses. And how do we better advocate at that intersection? Or how do we build those pods that Gabriel was talking about? How do we rest, rest, pace, and oh, I lost my page. Y'all know what I'm saying.
You stop, rest, and pace.
Face and stuff, and really take care of ourselves, be intentional, trust our bodies, and know that we know what's going on. And if you don't, be persistent until you get the right answer. So I want to bring on Heather and really thank the Reunion Project for having me moderate. And this disability justice, this kind of intersection is new for me, and I love it, and I'm just really excited. So Heather, you want to represent the Reunion Project, come on and say a few words.
Yeah, absolutely. I just want to thank, first of all, Vanita for being an amazing moderator, and Gabriel and Dr. Peluso and Philip. We couldn't do this without you, and we're so thankful for you. So yeah, snaps for you. I just want to let everyone know that we have some upcoming TRP events. We have one of our town halls that is going to be happening in Charlotte. The theme for that is going to be breaking boundaries with resilience. This is an in-person event. It's going to be happening on September 22nd and 23rd. We have some information about our host committee there, our co-chairs. If you'd like to contact them, you'll also get this slide deck in a follow-up email tomorrow. If you're interested in having a town hall in your area, in your location, please reach out to us. Please let us know, because we want to be there too. Yeah, and other than that, please stay connected with us. We are on Facebook, we're on Twitter, Instagram. Reach out any way you can, shoot us a message. If you'd like to be added to our listserv, let us know. We want to make sure that you're getting our communications. It's very important to us. Our next toolkit series webinar is going to be in September, so be on the lookout for some information about that. These toolkit series webinars have been super successful, and they have been because of you all who are showing up. So thank you so much, and I hope everyone has a beautiful, beautiful day. Thank you.
Bye, everybody. Thank you.
Thanks so much.
Thank you.
Thank you.